Hi, my name is Kristen and I'm one of the assistant nurse managers in the ICU. Together with Kelly, our educator, and the rest of the ICU leadership team, we are implementing chaos-free code blues. Evidence-based practice has shown that clear role definitions during in-house cardiac arrest can lead to a reduction of providers that respond, therefore decreasing the chaos and confusion that ensues. Chaos-free code blues include 9 defined in-room roles that consist of RNs, RT, and an MD. Because respiratory therapists are vital in resuscitation efforts, collaboration on this project is imperative to its success. We engaged our intensivists and they are on board and excited to start this project as well. Our ask is that you be open to these changes. At the termination of each code, you will find we do a debrief. This is where constructive feedback may be given and is not meant to be punitive, so please be open to these changes as well. Our goal is to align our resuscitation efforts with the AHA standards of resuscitation. In conjunction with RQI, chaos-free codes will ensure we follow AHA guidelines. RNs are going to receive this training at our upcoming skills fair as well. In this video, you are going to learn the 9 defined roles as well as see them acted out in a mock code blue. Thank you for your cooperation and collaboration on our project.
Number 1, I stand in position number 1. I'm at the head of the bed. I assist with BVM, insertion of oral airway. I prepare for intubation. I set up suctions. I assist with supplemental oxygen and position the patient.
I am RT number 2 on polyspot number 2. I remain at the head of the bed, primarily responsible for BVM, ensures proper ventilation per ACLS guidelines. 30 to 2 for non-intubated patients, 1 breath 6 seconds for intubated patients.
I am CPR left. I am on spot 3. Can be an RN or an RT. Perform high quality uninterrupted CPR. Audible counting during compressions. Alternates compressions with right CPR every 2 minutes.
I am on polyspot number 4. I am CPR right. I can be an RN or an RT. Performs high quality uninterrupted CPR. Audible counting during compressions. Assures backboard is in place.
I'm RN Meds. I assess and or place IVs, accept med orders and administer medications, assess current medications infusing and request refills as needed.
I am RN defib. I'm in spot number 6. I connect the patient to the defib pads and monitor, provides defibrillation, cardioversion as needed per direction of the team leader, distribute supplies as needed.
I am RN team leader on polyspot 7. I lead the resuscitation team according to AHA standards and identify reversible causes. I am able to correct errors and assist with duties as needed. I follow time guidelines for pulse checks and medication administration.
I am the recorder. I am on polyspot 8. I record all events and give information to leaders requested. I ensure that the code start time is not the same time as the first compression.
I am the MD. I'm on polyspot number 9. I collaborate with the RN leader following AHA guidelines of resuscitative measures, and I ask, am I missing anything at the end of the code?
The caregivers on call. We wait outside the room and we are available to rotate in for CPR and act as a runner for miscellaneous items. Mr. Jones? Mr. Jones? Mr. Jones? Call code blue, I need help! I need help, can you start bagging, please?
Code blue, ICU, room 2211.
Compressions, please. Someone get the crash cart!
Coming in the back.
Okay, let's go. Do we have a working IV?
627.
IVs working.
Can we get hooked up to a defibrillator? What happened, Kelly? We have Mr. Jones. He's a 52-year-old male. Just had right arthroplasty. Came in to check on him for my morning assessment, and he's unresponsive. He wasn't breathing. I called the code blue. We're just starting CPR and our first round. Of what meds have we given? We haven't given any yet. Okay.
Change it.
One in the FE. We're setting up our great compressions. Let's keep that going so we can analyze a rhythm.
17 and 18 and 8, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1 and 2 and 3 and 4 and 5 and 6 6 and 7 and 8 and 9 and 10.
Did we give the
and
epi
11
yet?
And 12 and 13 and 14 and
Let's give an
15
epi.
and 16 and 17, 18 and 19, 20, 21, 22.
Perfect. Monitor hooked up.
1 amp of epi in.
27, 28, 29, 30. 1 and 2, 3 and 4.
Recorder, how many minutes are we at?
7 and
We're at
8,
1.5
9,
minutes.
10 and
So
12,
30 seconds till a pulse check, and let's analyze a rhythm at that point.
Before we stop CPR, can you find a pulse?
20,
Find a pulse? Anybody?
24, 25,
Find it. Do you feel a pulse with
No
CPR?
pulse.
19,
Arlene, what's our end tidal CO2?
23, 24, 25, 26, 27,
2 minutes.
9, 30.
2 minutes, let's check a pulse. Analyzing rhythm.
Analyzing now. Stand clear. Remove test cloud.
Do we have a pulse?
I don't feel a pulse.
Continue chest compressions.
12 and 13.
What's our end tidal
14,
CO2?
15, 16,
10.
18,
Can we go a little bit deeper and faster, please?
23, 24, 25,
Let's give another epi.
27, 28, 29, change.
Another epi in. 1 amp epi in.
Second ask was epi in.
Can we also give bicarb and calcium?
Bicarb in.
Bicarb in,
Calcium in.
calcium in.
Can we prepare for intubation? RTs, are we ready?
Yes. We're ready.
Set up for intubation and grab the end tidal CO2.
Grabbing end tidal CO2 machine. Catherine, can you assess if there's a pulse during compressions for when we stop?
There's section.
How much longer till we stop compressions to check the pulse?
30 seconds till the next pulse check.
Debriefing is an important strategy for learning and for improving performance. Debriefing is defined as a dialogue. The function is to identify aspects of team performance that went well and those that did not. The discussion then focuses on determining opportunities for improvement at the individual, team, and system level. This may also be known as plus deltas. Together, we will review the overall situation, evaluate teamwork, assess aspects of airway, compressions, and medications or defibrillation, equipment availability, and have an open forum. To be effective, a debriefing must be conducted in a manner that supports learning. Thus, the purpose is not to identify error and assign blame, but to understand why actions and decisions made sense to clinicians in the moment.
Do we have an oral airway? No. May I please have an oral airway and ET to go? I said that's from the